Welcome, everybody. I'm Claudio Diaz. I'm going to be moderating the HIP session number 2. We're going to invite Dr. Gray, who is going to help us to understand better a strategy to persuade our patients to go home the same day.
Okay, thank you so much, Claudio. So I really appreciate the opportunity to talk about this particular topic because, number one, I'm very passionate about it. Number two, I would say probably the most important thing that has happened to me in my professional career in the last 10 years has been the development of an outpatient program. So it's a passion of mine. I've been doing it since 2016, and I really feel strongly about it. So hopefully I can give you all some useful stuff here this afternoon. And one point I would make is just not only do I think home same day is safe, I actually think for most patients home same day is safest, and I'll share some data about that. But this is one of the main arguments I try and make with my patients when they ask about this. So, we've talked a fair bit about outpatient arthroplasty. I think this is born of several things. It happens to be something that actually benefits all of us. I think it benefits physicians. I think it benefits patients. It benefits payers as well. But CMS has gotten behind this. Value-based care programs have played a role. And then lastly, we thought that this was good for our patients, and it gave us an opportunity to move into the ASC space. And I think all these things have led to a big uptick in outpatient surgery. If you want to get a very passionate and very informed opinion, I would recommend reading this article by Atul Kamath and Charlie DeCook, as well as Jeremy Staten, who was a fellow under Charlie. But this is an incredible summary of all the value that can be delivered by having an outpatient ASC-based practice. And now they were focused on knee in this paper, but all the same things apply for hips as well. So I'd encourage everybody, especially the trainees, to take a look at this if it's something you're interested in. So I would say, as far as just helping patients understand that this is safe, I think, number one, you really need to build an outpatient program. This shouldn't be something that you just kind of take on the fly, but you should look at it as part of a comprehensive program. And if you do all these things, and this is a slide I shared a couple years ago as well, but if you do all these things, you can really have a successful program. Number one, you need capable and engaged surgeons. The surgeons have to believe in this. I think all of us in the room hopefully feel that we're capable of meeting these sort of thresholds, but you want predictable times in your surgery, you want predictable EBLs. This just makes it easier on you and easier on the patient to be successful. Your anesthesiologists have to have buy-in too. They should be expecting that the patients are going to go home. They should approach these patients as if they're going to go home, and that can change some of the anesthesia protocols. And there's a lot of variation that is acceptable in this space in terms of spinal or TIVA, but you need to have a plan, and it needs to be discussed with your anesthesiologist. Another point I'd make is from the nursing/PT side. I used to emphasize the value of PT. I frankly think that PT is probably unnecessary if you have an engaged nursing staff. We use nursing now alone in our 2 ASCs for these patients. They do not see physical therapy. I think physical therapy is one of these legacy things that's in our hospitals that we use, but you can train your nurses to mobilize these patients very well right after surgery. And finally, you need to engage patient and caregiver and a facility that is all bought into this too. I mean, some of this stuff is obvious, but facility alignment is important. This just briefly is a paper we published a few years ago comparing our experience doing outpatient surgery in the hospital versus in a true outpatient setting. And you can see the important difference here is this spot right here. They spent almost 3 hours less time in recovery room. These are the same patients having the same procedure, just some had it in the hospital due to scheduling conflicts rather than over in the outpatient building. And you can see it's a 3-hour surgical time difference in the total episode. So the facility really can buy in, and this reflects different paradigms in the recovery area, but it's important. So I'd say once you have your outpatient program built, number two, you really need to spread the messaging. So everyone who touches the patient should believe in and be aligned with your goal of an efficient, safe, and outpatient surgery. And if they're not, you're going to run into problems. So obviously that includes you, your trainees, and the office staff. Your PA should believe in this. Your MA and nurse should believe in this. A lot of patients will come in and they'll start trying to get some data or some input even before they see you. They may say, oh, I hear Dr. Gray is sending his patients home. Is that really good? So before you've even seen them, they're trying to solicit some input from your staff, and so everybody needs to be bought into this. Same thing will happen in the hospital or in the, where you're operating. If the nurses and the PSTs, they'll try and get this information from everybody, and so you want everybody to be engaged in the same message. I highlighted anesthesia and the PT because they are two of the biggest saboteurs. They will absolutely torpedo you if they're not bought in on this whole plan. Next thing, obviously, choose patients wisely. So this was from our review of our first 100 cases that we did on an outpatient basis, and you can see these were the medical and social and surgical factors we had identified as being sort of pivotal. We probably gave a lot of emphasis to the medical factors early on, but over time, we really switched to paying a lot more attention to the social factors. RAPT score is a big one. A RAPT greater than 8 is very predictive that they will be able to go home successfully. Proximity to hospital probably still matters, especially for the reluctant patient, to know that they're going to be close by in case there's a problem. But then surgeon discretion and patient desire and motivation are two other key pieces. So what if the patient's reluctant? These are a couple questions you may hear. The patient may say, I just feel safer in the hospital or staying one night. The response I always have to that is the hospital is a great place to get sick. You're actually better off the sooner you can get out of the hospital. And a lot of patients kind of laugh at that and they, oh, yeah, that's true. I guess that makes sense. Will I be able to get around the house okay after the operation? And I tell, especially with hip patients, say, in fact, you're going to be getting around probably better than you are now, certainly within a day or two. And in the first day, they have the advantage of having Decadron on board. They have the advantage of having their local anesthetic on board. So they actually feel really good that first day. And then they start moving around very well. And the hip patients really generally have minimal pain. And so often they're hobbling around now with a bad hip, and you're going to make them better. They're actually going to be able to move better. And then some will ask, well, what if something happens? I always emphasize complications are very rare, but when they do happen, and thankfully not often, but they usually happen once you're home either way. And there's been some data on this. This was published by Max Courtney, who was one of my former co-residents, looking at short-stay patients. And the vast majority of complications in 1,000 patients that they reviewed happened more than 24 hours post-operatively. So patients may have this idea that, oh, something bad's going to happen. I want to catch it while I'm in the hospital. Well, if something bad does happen, they're likely not going to catch it when they're in the hospital, but thankfully that's rare. Looking at our outcomes after the first year, we were very successful by sort of taking that approach. We currently send 95% of our planned outpatients home. Those are some of the failure causes which we've talked about. The other thing I like to emphasize, just in terms of understanding the safety profile, this was from the publication I mentioned a minute ago, looking at our matched group of patients who had surgery in the hospital versus the outpatients. So these are basically aged and CCI matched patients. There's actually a lower complication rate in the patients who went home. And so, I think this just gives us more confidence to tell our patients that, no, this is a very safe option. Finally, if they're still reluctant, this is kind of the hammer that I'll sort of drop at the end here. And this relies on you having a good rapport with your patients. But I always emphasize to them, look, if I was in your shoes, if my family were in your shoes, unquestionably what I would want for myself or my family would be to go home from surgery. And that usually is enough to convince the more reluctant patients. If they're still hesitant, another trick that can be useful is you can send them for a single session of pre-op, quote, prehab. This has been shown in several studies to actually improve time in recovery room. You basically show them how to use a walker, show them how to transfer from the bed, transfer to the toilet, and all that can be done in just a single session of pre-op PT can help allay some of their fears. So the last thing I would say is, I call this burn your boats. Once you move to an outpatient center as soon as possible, it really is a good stress test for your program. It also makes sure the patients know, look, you're going to go home today. There is no bed here. And I think this was a really strong way to help people. If they want to have surgery with you and you tell them, yeah, this is where we're going to operate, you're a good candidate here, it gives them that sort of sense that you have total trust in the system and trust in them. So sort of in conclusion here, I would say, number one, just you got to start the flywheel spinning. It's okay to start small, build your program, but then start small and choose selective patients. Success with this, as you get that flywheel moving and turning, it begets more success, and it makes for easy and consistent messaging all across the board. It becomes the standard. So just to review this briefly, we started in 2016, as I mentioned, and you can see in 2016, we actually started in December, so we only had a couple patients that met outpatient criteria that year. But over the course of the next 6-7 years, we ramped up to about 70%, well, 60% at the end of the slide. But I have my data. This is my last year since I left UF and transitioned into FOI. And you can see this is my personal outpatient rate. These are same-day discharges, and this is all comers, so hovering around 80%. So I think somebody mentioned yesterday the upper threshold is probably right around this number. 75% or so is probably a reasonable expectation. But I think hips, knees, anybody can have this, and it can work very well. So thank you for your time. I appreciate it.
Thank you so much, Dr. Gray. We'll take the questions at the end of the session. Now we invite Dr. Hogan, who is going to tell us about the different strategies to close the wound.
All right, thank you. Again, my charge was to try to provide some evidence on what we should be doing for closure, and there was a pretty good study just recently published, a consensus statement of several orthopedic leaders, some in this room, telling us how we should close. I was asked to ask a question of one of these authors, Dr. Higuera. Do you close your wounds? All right, here we go. So the objectives, we're going to quickly go through, some risk factors for poor wound healing. We'll review some literature around the closure of hips, and then based on approach, and then we'll briefly look at high-risk revisions or patients like that. I mean, this is what we're trying to avoid here. This is, what we really don't want to see is wounds that are macerated or, an anterior hip there where we're trying to take a stem out and a massive, huge leg. So what is the evidence around how we can safely manage these patients? So I think we're all well aware of the risk factors for poor wound healing. This is an article out of Arthroplasty Today in 2019, and I think we would all agree that those conditions listed in Table 2 certainly increase people's risks of both deep infection, but also like superficial and poor wound healing. Interestingly, total knee replacement, just having one, is a risk factor for wound healing. That's a statistical error there, I would imagine. So. I found this very helpful. It actually just came out in June of this year. This is an international Delphi study on wound closure. So you have a bunch of thought leaders involved in this, 20 international orthopedic surgeons, all specializing in total hip. And their charge was to review the current literature and provide us some statements. So how this consensus started is that round one was an electronic survey, and they needed to have a 75% consensus agreement to make a recommendation. Then they went to round two, where they had a virtual face-to-face meeting. And then if things didn't change, then they came up with a final electronic confirmation. So these are some of the things that they looked at. So first, consensus statement on wound closure and sutures. The one that they looked at was sort of the new barbed sutures, or interrupted non-barbed sutures. And basically, and this is for the deep fascial layer, hopefully that projects, but 20 out of 20, 100% consensus, really there's no difference. You can look at industry-sponsored studies on barbed suture, non-barbed suture. We can all find something that makes our point, but in reality, as far as wound healing problems, there's no difference. Then they looked at time. And I think that what they found is it makes perfect sense that if you're using some sort of a barbed suture for the deep fascial planes, that it's actually faster. Okay, I guess we agree with that. Then they looked at, how does that affect cost? And this one, there wasn't as much consensus on. Barb sutures cost more. Are the time savings accounting for that cost? And I think there's a lot of fancy economics that we can do to make either case. But when I talk to my hospital or my fellows or residents, the reality of saved time in the OR is only good for one thing. That's either you're going to put another case on, or there's no more cases and the staff gets to go home. Then the hospital actually saves money. Beyond that, saving 10 minutes in the OR is not equivalent to the $45 a minute or whatever. That economics doesn't really work in my mind. Where I'm at an academic center, there's always cases going on. We have 45 operating rooms at our main hospital. So if I end early, my team sometimes is mad at me because they get the perianal abscess add-on that they have to do. The next statement was looking at, lower risk of superficial surgical site infections, sutures versus staples, and the consensus statement was that some sort of suture, we'll get to whether that's subcuticular or a external suture, but that there is a slightly decreased risk of superficial surgical site infections and wound healing problems if you use some sort of suture over staples. As far as cosmesis, there really was incomplete evidence, and there's really no consensus statement on cosmetically what looks the best. What about alternatives? Skin glue or other products that are out there that have maybe mesh and glue, hooked together, and really this group found no difference. They asked patients what they found and looked through the studies and, what do patients prefer? And there seemed to be a higher patient preference for subcuticular closures. I think maybe cosmetically it looks better, although that can't really be proven with literature. I'd say there's no doubt a patient preference towards not having to have something removed in a couple of weeks. That's nice. You don't have to have staples clipped out or sutures cut. And then closing time, again, they sort of looked at that, and no surprise, staples are faster than running sutures or interrupted external sutures. So what about dressings? I think that most of the literature, and this was about 80% consensus statement, that some sort of occlusive dressing decreases the rate of surgical site infections and wound healing problems. This first statement gave the advantage to sort of a mesh adhesive versus silver impregnated dressings. I don't think that you can really hang your hat on that. They both do well. Then they looked at just wound complications, insufficient evidence. Obviously, occlusive dressings require fewer changes, so I think most of us nowadays are probably using some sort of an occlusive dressing. And then as far as approaches, at least this group, we talked about it earlier during the case journal club, are there differences in wound complications based on approach, anterior, posterior, lateral? In general, no. But being an anterior surgeon, I would say that that's probably not true. I think all of us that are anterior surgeons recognize the proximal portion of our vertical incision has a little bit higher risk of delayed healing, without a doubt, So the next thing they sort of looked at, there's the approach thing again, and then drains. I don't think anyone uses drains really in 2024. And then there was a medical thing there as well. What about negative pressure wound therapy? We'll look at some other studies on that in a little bit, but there seems to be a pretty good consensus statements that if you deem the patient to be high risk, that applying a self-contained negative pressure wound therapy vehicle decreases their risk of wound complications. And that was true when compared both hips and knees. I'm not familiar with these sutures, these triclosan-coated sutures, the antibiotic sutures. I think they're really expensive. We don't have access to them in our hospital. But at least the Delphi group here seem to say, and I think there's some smaller studies that show a slightly reduced risk of infection when you use these coated sutures. So what about high-risk wounds? This is an article written by Carlos. It's great. I read through it a couple of times, and just the science and the physiology behind negative pressure wound therapy and how it works. These are some of the big statements of how negative pressure wound therapy can improve wound healing by modulation of inflammation, promotion of angiogenesis, granulation tissue. It's a really good article if you have time to read it. But Dr. Hansen, who's in the audience, published on this way back in 2013, 109 patients. And this was actually post-op, so this was not placed in the OR, but let's say we did a gauze dressing or an occlusive dressing, and it was draining. He showed us that placement of negative pressure wound therapy in the already at-risk wound, the one that's draining, they showed 76% of the time they were able to resolve that drainage. Now, granted, look, 10% of the patients ended up having a superficial IND, 12 had a deep, and 3 of the 109 patients that were already draining ended up with a problem, so 24%. But I think the power of these negative pressure wound therapies are immense. And even if you don't want to use it right off the bat, keep that as a toolbox item for the at-risk wound. One other study, a systematic review and meta-analysis of only RCTs, and the take-home points here were negative pressure wound therapy decreases the risk of SSI and revision total joint. It also increases non-infections wound complications, however, though. You have all this tape, people can get sensitized to it, so blisters are very common. Lots of calls to the office for malfunctioning. So again, pros and cons to this negative pressure wound therapy that I think you and your office staff need to pay close attention to. So what do? For primaries, I close the fascia with the #1 interrupted Vicol. My rules on subcutaneous is I put a layer of suture in for every inch of fat that we have to close, and not real tight. I'm not trying to necrose all the fat, but just to pull that together. Then we'll do subcutaneous 2-0 monocryl, interrupted, buried, and then a running 3-0 monocryl. And then I like to seal things up. I do Dermabond and Steri-Strips. The Dermabond goes on before it's dry. The Steri-Strips are going on there so they actually get glued to the skin, and then an occlusive dressing. Revisions, a little bit different, non-absorbable Ethibond. Same for the layers. The real difference is every revision for me, the skin's closed with a nylon. We don't know how much those patients swell. It's highly variable, but you can keep nylons in safely for upwards of even 6 weeks. And then I have a low threshold for negative pressure wound therapy in my revision cases. So thank you very much. We all want our incisions to look like the ones on the right, not the left. Thank you.
Thank you, Greg. Thank you so much. Now we're going to invite Dr. Barry, who is going to explain us the way he approached ME arthroplasty through the A.
Yeah, so this is a talk just for Dr. Barber. These are his 2 favorite things, cemented hips and anterior hips. So we're going to combine them together. All right, so these are disclosures, still the same. And there's multiple vendors that have all the things I'm going to show. So we talked about this already. Hemis and cemented hips, the smaller proportion of all of our hips, about 8% are hemiarthroplasties. And we're seeing more totals for fracture, but kind of put both these in the same category. They're femoral neck fractures or they're older patients that need cement. They take longer, they're in the hospital for longer, they're sicker patients, they need to be treated maybe a little bit differently. And so this talk is not about this. Like, I'm not going to discuss anterior versus posterior, all that stuff. I don't think we need to talk about that. There's data that in femoral neck fractures, posteriors may be a little bit higher risk of complications, but we're not going to go into that. We're just going to talk about if you want to do an anterior cemented hip, how are you going to do it? So last year I gave a talk about the merits of cement, and you've heard it a little bit this morning. You've also seen that even despite some of the data that we don't like to cement because it takes longer, we're not trained in it, we're worried about killing patients, we don't like taking it out later, and then all Americans are super active and fit and they need a better durable press-fit bond, right? So that's what we talked about before, and this is the data. The data would say cemented is going to do better in all these hemiarthroplasties and in these sicker femoral neck fracture patients, but we still kind of ignore that. We ignore that they're going to live longer and have less mortality. We also know about collars and how they're maybe better and have decreased fracture risks compared to non-collared stems, and that goes to cement too. But even despite this, we still see a lot of patients getting press-fit implants. So 25% of our revisions early are linked to fracture. And we've seen this data, so I'll kind of skip this. They don't fracture as much as if you cement them. Dr. Nassif showed this earlier, but we're getting a slight resurgence of cement in both hemis and totals since kind of the bottom there in 2017. It's been creeping up in percentages, but still about half of femoral necks are being treated with press-fit implants. And this is that same data about femoral neck fractures by age group. And so the far one over there, over 90, still only about 50% of people are cementing patients over 90. So only half of you would cement that guy if he showed up in the ED with a femoral neck fracture. So why are cemented DA hip rates low? He's getting cemented every time. Why are cemented DA hip rates low? Lack of appropriate instrumentation, maybe historically. Lack of comfort. We're concerned about getting necessary exposure. What if something bad happens? We might not be able to get ourselves out of it. And then we always fall back on cementless is faster. So hemis from the DA are even more rare, and I think a lot of that maybe has to do with a lot of us that are doing DA are arthroplasty surgeons, so we know how to do a total, and we're just going to do a total. And then for me, pretty much only the anterior hemi is going to be someone who's very demented, non-ambulator, and then we're going for costs and kind of maximum fellow or resident benefit. So that's for hemis. Usually I'll do a total. But we know what we have to do, but we just don't know if we can do it, cementing from the front. So this is a beginner's guide for how to do that, and it's going to go better than the day trading that we all did during COVID. So setup, we're going to template the other side. For a femoral neck fracture, you still have a good side that you can template off of. That's going to help you with your neck cut. I use a table to do this. I think it is very helpful when you're trying to get exposure in a straight shot for a lot of these cemented stems. I also think the table helps with exposure. You can put a little bit of traction on the leg, and it reproduces the anatomy a little bit better during your approach. And then I have access to these self-retaining retractors, so this is a picture of me just doing a case by myself because I don't have any assistant. I think it also helps when you're cementing if you have some sort of self-retainer, so you don't have to worry about people moving or altering the position of implants while you're trying to wait for cement to dry. The approach is just a standard approach. I do a lot of bikini incision, but I will not do that for any femoral neck fractures in case you do find a fracture propagating a little more distal than you want. When I start my capsulotomy, this is kind of the start that I'll do, and then I'll use a schnitt to kind of get underneath the capsule between the labrum to preserve it and splitting it all the way up. I'll freshen the neck cut and then put the leg in traction and external rotation and use a corkscrew to get the head out. When I'm trialing heads, so once the head is out of the way, I will trial the socket. I only use, almost every system has a bipolar trial that's 2 balls, and I will only trial the big ball first, and I'll just use what feels right, kind of the 3 little bears principle of one's too tight, it's not going in, one's too loose, you can kind of shuck it around, and whichever one is right. And then I'll leave the big ball in the socket. Socket's done, now I'm moving to the femur. The tips for femoral exposure that I try to get the fellows to learn is that when you're doing a cemented case or a hemi in particular, you already know their bone is bad. And so any step that's going to put extra stress on the bone, in particular the trochanter, needs to be very careful, and you need to give a release to that trochanter so it's not seeing undue pressure posterior or pointed towards the posterior direction. So I'll do a full intertroch release on all of these cemented cases. It helps with exposure. You know, when patients say, oh, you're not releasing anything in a DA hip, we all know that's not true. You're releasing some of these tendons in a lot of DA cases, but cemented in particular, I'm very aggressive about releasing the conjoint tendon and even the piriformis most of the time to really get that exposure on the top. So these are the tissues that you're taking off on the top up here to get a good exposure and not pull that troch posteriorly. When you're broaching, I think it's really important to clear the lateral neck really aggressively. These are not your DA-friendly stems. They don't have a shoulder relief, so most of us DA surgeons are not used to really getting over there and being worried about being in varus. When you're doing a cemented stem, you need to. I use offset broaches for all the DAs. You know, this is dealer's choice, whatever works well. I like kind of these, they call it a Mata-style offset, which is a very aggressive angle that you can see there. You can use manual, you can use automatic, doesn't particularly matter. If they have absolutely horrible bone, I am not afraid to skip trialing. So, and this goes posterior or anterior. If you can't get a stem that's stable when you're broaching because the bone is just so atrocious, you should not be rotating and trying to reduce that hip. Just buy what your templated cut was, make sure it's close, and then you're going to cement it in before you trial. That's when you're going to fracture something, is the torsional stress of reducing a hip. Most hemis, you're not going to be worried about a couple millimeters of extra length, so just maybe leave it a little bit long. So you can see how much cement goes into some of these hips. When I'm trialing a hemi, we have left the big ball in the socket, and so you're going to orient that big ball to accept the small ball during the reduction. So you can kind of see if my hand is the socket here, I'm orienting that ball so that it's just going to slide right in during the reduction maneuver. Don't have it oriented in this direction, that it's going to be harder to reduce. And then you can take your normal fluoro shots. I usually take one shot to see the stem, make sure we're not embarrassed and we're properly sized, and then one shot to get leg length. You can do the same thing with these trials. Dislocating just the same way, opposite. Dislocating the small ball and then taking the big ball out. So we're going to prepare the bone for cement. Coming from the front, I think a flexible restrictor inserter is a must. You can't get the straight metal ones down, so you need something that has a flexible tip. They make these kits. One of the companies makes a kit like this. All I use out of this is the restrictor and the flexible inserter. But you're going to use that so that you can kind of get around the corner and get it all the way down. Never hit that with a mallet. It will break the lateral bone. You just want to kind of tap those in. It should go pretty easily. Then we're going to clean the deep tissue with a pulse lavage system. Don't forget to clean proximal as well. One error I see is people just put it down in the bottom and spray at the bottom and then pull it right out. You have to clear the blood and fat from the whole canal. Then I dry it, so I'll pack vaginal packing in. I'll cut the vaginal packing in half. Half will get an epi-soaked saline mix. The other half will stay dry. And so the first pack is the epi-soaked saline going in. While that's going in, the scrub on the back table is mixing cement. And so when cement is almost ready is when then I take the wet epi-soak sponge out, I'll pulse it again, and then I'll put the dry lap in. So we're as dry and as clean as we possibly can be. Now, in terms of looking at the cement, this is kind of the spider web test that you want to see. I don't know if it actually projects pretty well, but you want this thing to be dripping down and have a certain viscosity to it before you're sticking it into the canal. If it's too wet, when you pressurize, it's just going to move around wherever the holes are. If it's too dry, you're not going to be able to get the stem down. So there is this kind of in-between, and you'll see the cement with a little drip just kind of going all the way down without tearing, and that's when you're kind of ready. It's usually about 4 or 5 minutes after this is called simplex, or a low viscosity cement. When it's time to cement, inserting the cement is just as important as anything else, and you got to stay in front of it. If this cement starts getting around the tip as you're pulling back, you're going to take the whole column of cement out with you. So anytime you're pulling back, you should be squeezing the trigger at the same time. It's better to let the cement drip in than it is to let it get around the tube and pull the whole column out as you're coming out. Some people will use a pediatric feeding tube, but that is such a pain in the butt to get that opened and down there. I just try to stay ahead of the cement. And then this is one thing from DA that I think works way better than from a posterior approach, is just the orientation of where your finger is you can get a ton of pressurization down the canal just by sealing that canal with your finger, or sealing the canal with your finger and then pressurizing. So just keep adding cement, pressurize, keep adding cement, pressurize. You can finish with the kind of plug, the rubber tip if you want, but I think this is the most effective way to get a good mantle. Then you're going to put the stem in and you're going to hold it in place. You kind of notice these are all the self-retaining retractors. This is where the residents get a little bit lax if they're helping, and that medial retractor will push the neck. So you always want to have a space between the neck and the medial retractor so you're not getting too much version. And then you just hold it in place. And so this is where these self-retainers and a HANA table, you literally just push it down, you put one finger on it, and then you talk to other people in the room. Final reduction, make sure everything's in where it's supposed to be. This is the hardest part of a Hemi from the front, is reducing. It's so stable that it's hard to get in sometimes, so use the table, lock traction on the other side. These are cases from our fellows, so our fellows do these from the front. They have not been doing it over a year. They're less than a year, they come in, they start doing DA Hemis cemented, and I think this is a technique that can be picked up pretty quickly when you're doing it correctly. Extensions, if you do get in trouble, I'm happy to talk to these about people, but the proximal extension from a DA hip is so easy. You just extend along the crest, release the front of the TFL, you're going to have a straight shot. It heals very reliably. You just sew it in line with your fascial closure. For the femoral extension, it's a little bit more complicated and probably want to do it on a cadaver. It's not something to just watch a video, but you can do it if you need to get cables farther down. So in summary, I think it shouldn't be scary. Use the right instruments. Beware of the dangerous spots. And if you're going to do an approach, you should know how to cement there. There's definitely going to be cases where you're going to find the bone worse than you thought, and having the ability to cement is important. So thank you.
Thanks, Jeff. Thank you so much. Now we will invite Dr. Gu, who will speak us about his approach to treat patients with spine and hip pathology.
All right. I have no disclosures. So I think this will be a different sort of a talk, but this will be more about how to evaluate a patient when they come in and they have this sort of hard to describe type of pain around the pelvic area. Patients in the clinic, we spent quite a lot more time identifying the location and the pattern of pain. A lot of time is spent during the history of asking the patient to identify where the pain occurs. These are key diagnosing characteristics and allow us to really kind of do the job of trying to find the pain generator. So a big deal of the evaluation is trying to find what is the source of the pain. It could be coming from the disc, the facet joints, sacroiliac joints, inside the hip joint, outside, contributors like tendon, muscle, and nerves. Also important is the pain history, how the symptoms started, past injuries or current physical demands, repetitive physical demands, any comorbidities or medical conditions that may contribute to risk factors or also be a part of the differential diagnosis. Any prior management, including injections and surgeries, may speak also to the possible condition itself. A key characteristic, especially for seeing a patient might have more of like a spine-related pain, is trying to differentiate between contributions of a nerve-related pain or neuropathic pain versus simply nociceptive pain. Each has different qualities to it, and they can be distinct, but also overlap with the other type of pain. So prominent characteristics of neurogenic pain can be described as burning or electric or shooting. Nociceptive, coming from musculoskeletal sources, can be described as achy, deep, or throbbing. They can be sharp, but neuropathic pain can also be described as sharp as well. The ways that pain aggravate and alleviate can further reveal where the pain is coming from. We often ask a lot about, like, what do you find during your positions and movements that are aggravating, and what do you try to do when you do have pain to try to relieve your symptoms. Commonly, hip flexion and aggravate hip joint pathology or tendinopathy. Sitting versus weight bearing can aggravate disc pain. Activities involving pelvic torsion or asymmetric pelvic loading can aggravate SI joint. And in terms of leading towards triaging the management, evaluating low back and hip complaints, we always try to assess for red flag symptoms or signs, raising concerns for urgent issues like spine pathology that might end up in neurovascular compromise, which may be less commonly associated with hip pathology on average, but these can often be indications for urgent treatment and referral to surgical management. So whereas imaging is also important for a correct diagnosis or to corroborate our presumptive diagnosis, imaging can also present with false positives, requiring providers still to determine whether a distinct pathology is causing the symptoms, which further speak to relying on accurate and specific hip and spine physical examinations. So key parts of the exam may help distinguish spine from hip pathology. Restricted range of motion in the particular affected body part may reflect local arthritis, among other pathologies at that particular site, spine or hip. Focal tenderness, we include a bit of time doing a lot of palpation around spinal-related structures. That might reveal discogenic pain, if it's interspinous space, tenderness, facetogenic pain, or even identify myofascial pain based on palpation of taut muscular bands. Local tenderness around the hip may reflect tendinopathies or bursitis. Here, I present some data related to provocative testing, which is also a standard part of our exam to identify and distinguish pain generators. Diagnostic performance of, or at the accuracy of hip exam to diagnose various conditions range from low to high. So for example, Fader test demonstrates high sensitivity and might serve as a really good screening tool. For the performance of examinations to diagnose nerve root impingement in patients with lumbar radiculopathy, a 2017 systematic review of accuracy studies of these exams demonstrate that diagnostic performance of most individual index testing ranges from low to moderate. So not a single exam might actually be like a revealing type of maneuver. Seated slump test was found to be more sensitive than straight leg raise. Straight leg raise and cross straight leg raise proved to have good specificity and possibly good utility to rule in or confirm lumbar radiculopathy. As far as being key examination steps, motor and sensory testing across studies still demonstrated relatively poor sensitivity. And I didn't include this here, but related to facet joint testing, Kemp's test, where you extend or rotate, has limited efficacy or limited accuracy, and there's poor diagnostic accuracy. For the sacroiliac joint, individual provocative maneuvers have modest sensitivity and specificity. A lot of recommendations from studies recommend performing multiple tests. So often when we're suspecting an SI joint pathology, we'll do a series of at least 6 examination maneuvers to improve the diagnostic accuracy. Multiple positive provocative tests you'll see as you run down that list start to improve specificity. Having 3 or more provocative tests out of 6 was suggested to have the best predictive power in relationship to confirmation studies coming from intra-articular injections. A 2020 study suggested the combination of Faber and thigh thrust improved the overall diagnostic ability more than any other combination of exams. Presumptive diagnosis for hip or spine pathology can be made still based on the history and the physical examination to guide appropriate imaging studies and initial management, which often includes physical therapy. Imaging studies still can portray the severity of pathology, improve specificity, but there still isn't always a direct imaging correlate. Structural findings on imaging don't always have clinical relevance. We find that the case is very true with relationship to lumbar spine MRIs. And therefore, injections can, in some instances, further increase specificity of diagnosis. Here, findings from various case series indicate the response to intra-articular hip injections has high sensitivity and specificity for diagnosing hip intra-articular pathology. For radicular pain, however, from a 2013 update on guidelines for treating chronic spine pain, the evidence for the accuracy of diagnostic selective nerve root blocks is fairly limited. There may be somewhat of a difference between performing the selective nerve root block versus a transforaminal injection, which places the needle slightly deeper into the foramen, which we still perform to support our spine surgeon colleagues to help them increase confidence of their surgical levels. For sacroiliac joint and facet joint, the analgesic response to a joint intra-articular injection rather than imaging findings is considered the gold standard for diagnosing dysfunction from those joints. In 2015, a systematic review for the diagnostic accuracy of SI joint pathology, the evidence for the accuracy of SI joint pathology is level 2, relying on dual diagnostic blocks with a cutoff of at least 70% relief from injection into the joint. So we may end up performing multiple exam maneuvers in clinic to raise our confidence that it's the SI joint, but it leads towards performing the injection to confirm the diagnosis of SI joint pain. And lastly, for facet arthropathy, guidelines in 2020 from ACIP suggest there's level 1 or 2 evidence with moderate to strong strength of recommendation for using diagnostic facet joint nerve blocks as the diagnostic standard for identifying facet arthropathy. These days, I think our cutoffs are if the patient receives 80% relief from dual diagnostic blocks, so it actually takes a series of procedures, at least 2, for them to actually reach the management, which is the radiofrequency ablation. As far as management, starting with presumptive diagnoses, we end up ultimately relying on physical therapy as a basis of treatment. When it comes to pelvic conditions such as the SI joint, I think we always try to keep in mind the value of pelvic floor therapy in addition to lumbar and core strengthening. There's a lot that relates to microinstability related to the musculature around the pelvis, that if patients don't benefit from lumbar spine PT, they may actually benefit from pelvic floor PT. We're always mindful of the ability of the patient to participate in PT. Sometimes we'll favor doing injections ahead of time to bring their pain down, to allow them to participate in the PT. If they can't weight bear because of hip pathology or severe sciatic pain and they rather not have injections or procedures, we'll often recommend aquatic therapy and then have them perform exercises in an offloaded environment. But often it employs a few rounds of discussion with the patient to employ a multifactorial approach A lot of that might speak to managing pain through other modalities, heat, massage, electric stim, maybe exploring acupuncture and the like. All right. Thank you.
Thank you, Peter. Thank you so much. Now we will invite Dr. Eric Hansen, who will enlighten us with different concepts about true diagnosis.
What's that? Okay. Thanks, Claudio. I've been tasked with talking a little bit about trunnionisis, which is an increasingly recognized failure mechanism in total hips. So to start, I think it's important to clarify, while there are multiple modular junctions or tapers in total hip replacement, trunnionisis, as I'm going to refer to it in this talk, refers specifically to an adverse reaction to metallic debris at the Morse taper of a metal head on a polyethylene-bearing total hip. This is going to be the outline of the following talk. So recognition of these corrosion products on the Morse taper and the introitus of a cobalt chrome head is nothing new. Initial reports were described as late as or as early as the late 1980s and early 90s. I remember as a resident when I operated with Dr. Jurgensen in a revision for an alternate type of failure mechanism, we would use a Bovie pad to scratch the corrosion products off the taper. And at that time, I don't think we recognized what we were seeing or what the implications of what we were doing was at that time. But this recognition of trunnionisis as a true pathologic mechanism is gaining increasing awareness. And I think a lot of that has to do with our experience with the metal on metal phenomenon over time. So the prevalence of revision surgery specifically for trunnionisis has been reported anywhere from less than 1 to 3% of all our total revisions. Now that seems like a fairly low number, and the smaller number is from large registries and the higher number from single center institutions. And I think we all recognize there's wide regional variations in practice patterns and implant usage, but this number is very likely an underestimate because the indication for revision may be associated with one of the other concomitant failure mechanisms like instability, infection, or loosening. The time to clinical presentation in revision surgery ranges from 3 to 7 years from the index procedure. So the pathomechanism of trunnionisis is still incompletely understood, but it has been described as mechanically assisted crevice corrosion. Specifically, this means that there's galvanic corrosion between the cobalt chrome head and the titanium taper, which leads to loss of the passivation layer and then resulting oxidation of the metal alloy. This is then exacerbated by mechanical stresses and micromotion at the two surfaces. The diagnosis of trunnionisis from a history and physical examination has a widely variable presentation. It can range from the asymptomatic or minimally symptomatic patient with a completely benign exam. A patient may present with a painful total hip and positive provocative tests, and it can go as far as a patient with a history of recurrent instability and evidence of severe abductor weakness. Similarly, the diagnosis based on imaging using plain radiographs also runs the gamut. It can be a normal X-ray, only notable for a hard-on soft bearing. You can see that medial scalloping of the calcar, which has been associated with ARMD, or the not-so-subtle complete catastrophic trunnion failure. Interestingly enough, the patient on the left with the completely normal X-ray actually had the most complex clinical course with multiple surgeries, initially for instability and ultimately for a recalcitrant infection. Next, if you have a concern for trunnionisis, you should proceed with a Mars MRI. How do I get it to run? Never mind. So it's probably not going to run. But you're looking for specifically a pseudotumor or any damage to the abductor complex, as that will help guide management when you do the revision surgery. The workup in terms of laboratories will consist of getting a serum cobalt and chromium level as well as an ESR and CRP. The data suggests that any metal ion value greater than 1 microgram per liter, or a different way of saying it is part per billion, is indicative of an adverse reaction to metallic debris of a metal on poly total hip. There is a pathognomonic predominance of cobalt to chromium at a rate of 2 to 1 to 5 to 1 for trunniinosis. And this is thought to be due to the fact that the cobalt ions are more soluble, whereas the chromium corrosion products precipitate in the surrounding soft tissues. In the cases of trunniinosis, you may still have elevated SED rate and CRP. And in order to distinguish that from a true infection, you should proceed with an aspiration. The adverse local tissue reaction may cause cellular necrosis and particulate debris, so it is important that you request a manual cell count. And what we're looking for, in contrast to an infection, is a lymphocyte rather than a neutrophil dominant effusion. There are some centers which are sending synovial metal ion levels, and they've found those levels to be orders of magnitude higher than the serum levels, though this is not something that is widely employed generally. Patient-related risk factors for trunniinosis include an elevated BMI and possibly an increased activity level, which makes intuitive sense given the increased stresses and loads across the bearing surface. There are a number of significant implant-related risk factors, with the most important being femoral head composition and head size, with the biggest culprit being cobalt chrome heads greater than or equal to 36 millimeters. High offset stems and those with shorter and smaller tapers impart more torsional forces across a smaller surface area, and this leads to accelerated micromotion. Historically, there are several wedge taper stems that have been disproportionately represented in these trunniinosis cases. What can we do as surgeons to mitigate the risk of trunniinosis? Well, we should always employ a meticulous technique of both cleaning and drying the taper before applying our femoral head, and then applying the appropriate inline impaction force when we mallet. Surgical treatment of a diagnosed case of trunniinosis is to revise the head to a ceramic ball with a titanium sleeve given the damaged trunnion, as well as exchange the liner and hopefully upsize the ball. In addition, we should debride the pseudotumor, and it's a balance between wanting to be aggressive enough without creating iatrogenic morbidity, but recognizing that any retained necrotic tissue is a potential nidus for infection. The picture here is what I've seen clinically in cases of trunniinosis. This is not the black motor oil sludge of the classic metal-on-metal bearing failure, but more looks caseous, cheese-like appearance of the periarticular tissues, and often the bone is pale and necrotic looking. Occasionally, we'll have to revise either the acetabular or femoral component due to component malposition, the desire to use a cup that accepts a dual mobility liner, or because of catastrophic trunnion damage. The outcomes of revision surgery for trunniinosis are quite sobering, with a very high rate of re-revision surgery, approaching 1 in 4 cases within 2 years. And if you look at the case on the right, it's no wonder that the failure mechanisms after these surgeries are PJI and instability. One particular study looked at risk factors for re-revision and found that not revising the cup, as well as the time from the index surgery to revision, were significant. One slide on dual mobility, as this was brought up earlier today. Dual mobility has a similar concern regarding the trunnion, because most implant companies have a cobalt chrome liner in a titanium shell. And this potential for corrosion is exacerbated by malseating of the liner. To date, there have been a number of case reports and series on this particular complication. And one systematic review looking at about 250 asymptomatic patients with a dual mobility construct found that about 5% had elevated cobalt levels, 2% had elevated chromium levels. So I think we still need to follow what we're doing over time to see the significance. So in summary, the diagnosis of trunniinosis requires a healthy index of suspicion on the part of the clinician because they will often present initially subtly. Any patient who comes to my office with a painful total hip will get a workup for both infection as well as an adverse reaction to metallic debris. Any ion value in a metal on poly hip greater than 1 should raise concern. And if you see that sort of 2-to-1 cobalt to chromium disproportionate ratio, that is pathognomonic of trunniinosis. Aspirations should be sent for a manual cell count, and we're looking for a lymphocyte predominant effusion. After plain radiographs, a Mars MRI should always be ordered to evaluate not only for a pseudotumor, but abductor pathology. And while revision surgery for trunniinosis seems relatively straightforward as just a head and a liner exchange, I think with the results being as sobering as they are, the outcomes are anything but straightforward. So it's our responsibility to counsel our patients preoperatively about how significant this diagnosis is, to employ meticulous surgical technique during our surgery, be prepared for contingency plans during the operation, and use dual mobility judiciously. Thank you.
Thank you so much, Eric. We will take 5 minutes for questions. Eric? What? Carlos?
I have a question for Chance. So, outpatient surgery, it's no question, is better for the system, better for the majority of the patients. But there's no doubt that from the business standpoint has affected us significantly, has affected reimbursement. And unfortunately, the pendulum has gone too far to the point that now it's very difficult to even justify inpatient surgery. But yet, for some of us that work in a safety net hospital, we still have a fair amount of patients that even if they are medically ready to be treated as an outpatient, from the social standpoint, we cannot. But yet, that's not part of any of the discussions in the peer-to-peer review or reimbursement at all. So my question to you is, how can we change that paradigm? I mean, I don't know if you really have a good answer, but I think that is, at the same time that we're in the podium talking about all the benefits of outpatient surgery, I think that we should really make a strong emphasis on, if we have grandma that is blind, lives by herself, and have an Uber driver to drop it in the outpatient center, that's not going to work, and the payers need to understand that.
Thank you for the question, Carlos. Yes, I agree completely that we maybe have been the victims of our own success a little bit in this space. So I think we all rejoiced in 2018 when TKA was removed from the inpatient-only list. We saw that as a victory for surgeons. What we didn't understand was that then, as you mentioned, the pendulum was going to swing in the other direction, where the expectation was everybody should be an outpatient unless you can prove justification for inpatient. I think that there has been pretty substantial work done by AAHKS in terms of the advocacy group in front of Congress to try and make that more a surgeon discretion where the surgeon gets to choose what the appropriate designation for site of care is. I don't know how successful they've been or what. I used to work in a health system where that had a big impact on my billing practice or where that was brought to my attention all the time. I no longer do. And so I sort of make the designation based on what the hospital billing and coding tell me they think is appropriate and works. And that's functional in my current practice, but I know isn't right for everybody. But I think ultimately we have to lean on our advocates from AAHKS to take this up at a very national level. I know Derek was on that council for a while. I don't know if he still is, but maybe he could. I'm not sure if he's here right now, but he may be able to give us an update. I'm not sure where they stand right now. I agree it's a big problem. And I think we kind of did it to ourselves a little bit, unfortunately.
So in terms of that, we're hoping that with the prior authorization process that we're going to require all payers to actually give us their outcomes in terms of site of care changes, in terms of denials for care. So that's the legislation that we're putting forward on that side for prior authorization. That's the goal. But my question for you, Chance, is your comment about having a place to stay afterwards and not having a place to stay. We're in an academic center. We're exploring making a surgery center. In your experience, would you recommend having a 23-hour option available, or do you think that's actually a bad idea because then it could sabotage you?
Yeah, thank you for the question. I think if you asked me to design my own site today, I would build a building with a 23-hour option, largely because I think I could do 95% of my work in that spot. But you're absolutely right that when I go to the hospital and I operate on an outpatient appropriate patient, the failure rate is not 0. Whereas when I do the same surgeries in the ASC, the failure rate is 0. And I think there is some sense that, you know, and again, PT gets their hands on them and raises doubts on occasion, or nursing raises doubts. It can come from anywhere. So I do think there's an advantage to having both options, but I think what we will find over the next few years is we can do the vast majority of our work with 23-hour stay. And so for us as orthopedic surgeons, that may be the ideal setup. And then you just concede that you'll have some of your planned outpatients spend a night, but that's okay. They're in a controlled setting that you have a lot more ownership over. So I don't know if the panel has any other thoughts on that. I'd be curious.
I want to finish with a question for Craig. Craig, after this lecture and being a master DA surgeon, do you think still that wound-related issues are the #1 problem we're facing with DA?
Yes, for sure. I mean, even though the consensus group didn't see an issue, and I'll be honest, I push the limits. Panis, if I can safely make the incision, I'm doing it, because my perception of the other benefits, lower dislocation rate, at least in my hands. I feel like I'm a better surgeon that way because I have some guidance. But the superficial wound healing problems are real, no doubt about it. I think my closure technique has helped closing the fat, preventing that sort of seroma from developing, glue. And then if they have a little bit of problems up there, I've found MetaHoney to be exceptionally beneficial to help with secondary wound healing. So we have that in our clinic. We give it out. But yeah, for sure, more complications.
Last question.
On that note, so Dr. Hogan, so say you have like an obese rheumatoid patient you're doing a DA on, do you change your closure? Like, do you use nylon and negative pressure? Or you treat everyone the same, and if they have a problem, then treat the wound issue?
For the most part, everyone's the same, that same closure technique I described. What I find hard, I think Eric was talking about, same way every time. Any amount of variability, and it may be right, may be wrong, but even just a negative pressure wound vac, well, then all the appointments have to be changed. Now that patient has to come back in a week to have it taken off, or maybe they're smart enough and skilled enough to take it off themselves. I don't know. I've found that closure technique with glue and a lot of things works for 99% of people, and then the ones that have issues I deal with. I don't know if that's the right way to do it.
Thanks. Is there room for one more question about, so this is more for metal on metal, not necessarily trunionosis. I converted a patient, bilateral hips, she metal on metal, had high metal ions symptoms. So all cobalt chrome is now out of her both hips. Her cobalt went back to normal, but her chromium is still high. Is that a problem? Do you do medical treatment for that? I don't know what to tell her. I consulted toxicology, but I haven't heard back. So
it's an interesting question, because I just got an email yesterday about a patient who was inquiring about chelation treatment. So I'm reaching out to the hematology group to see if there's anything that's currently available. I'm not aware of anything for that. And as I mentioned, the chromium precipitates are probably in the soft tissue somewhere. You probably try to debride as much as you can, but you can't debride everything. It might be a little bit intrapelvic too that you're not going to go after. I don't know what levels you're talking about, but it's something that I think would be worth following over time just to make sure it's not escalating and need to be removed. But the levels that we kind of worry about for true metal-on-metal bearings being at about 7 parts per billion, as long as it's not like double digits and growing, then I think you could probably sit tight on it.
So I had a patient that was similar that had a painful hip. We're doing the whole workup. We got all the records. There was no cobalt chrome in this person's body. And it's a dietary. You can get it from diet as well. So sometimes people that eat a lot of seafood, a lot of fish, will get heavy metals in their diet. And so then you just send them to the toxicologist and they figure that out. But it may be coming from somewhere, not the hip. So you got to remember about that too.
I'll add one last comment. I have a patient with the same issue. Been following her now for 2 years. She had a catastrophic failure of actually a modular Metasool, I think was the name of the, with the Pinnacle liner, or Pinnacle cup. And she was started by her toxicologist on N-acetylcysteine as a chelating agent and has been using it now for about 6 months. And we're seeing slow, steady decline of her levels. But that's the only one I'm aware of.
Okay, guys, thank you so much for your participation.